Imagine feeling perfectly fine while lying in bed, but the literal second you stand up, you start suffocating. Sounds wild, right? Like something out of a sci-fi movie? Well, jump right in with us, because in this explainer, we're diving into a fascinating medical mystery where a 90-something man's internal plumbing suddenly betrayed him.
So why exactly would standing up cause a man to gasp for air? That's our central puzzle today. We're looking at a super rare phenomenon that really forces us to think of the human heart as more than just a muscle, you know? It's a complex system of pipes and valves, and it interacts directly with gravity.
Let's set the scene. This elderly man comes into the ER with a history of heart issues, a bit of mild sleep apnea, and high blood pressure. Pretty standard stuff for his age. But over a few days, his chronic shortness of breath had suddenly, inexplicably, gotten way worse. At home, his portable pulse ox showed his oxygen levels just dropping off a cliff. But here's the kicker. His initial physical exam gave doctors absolutely zero clues to explain this terrifying drop. And here's the truly terrifying number we're talking about, 75%. His blood oxygen plummeted to 75% the exact moment he stood up. Just to put that into perspective for you, normal oxygen saturation sits pretty comfortably between 95 and 100%. So at 75%, your organs are literally starving for air. You're in a state of severe, life-threatening hypoxia. But, the true mystery wasn't just that low number. It was what actually triggered it.
Because his condition was completely paradoxical. Lying completely flat on his back, his oxygen was a perfectly healthy 96%. But standing up, bam, it crashes to 75%. Even just sitting upright dropped it to 84%. This is the exact opposite of typical respiratory issues like heart failure or lung disease, where lying down usually makes breathing harder, not easier. His doctors knew right then and there they were dealing with something completely bizarre.
Okay, let's move into the medical investigation. Initially, the doctors suspected the usual culprits, like pneumonia. They grabbed a chest x-ray, which showed a little bit of cloudiness, some opacification in his left lower lung. So they admitted him, started him on broad-spectrum antibiotics, and hooked him up to a BiPAP machine to help him breathe. But here's the catch. That supplemental oxygen barely even moved the needle when he was upright. His lungs weren't actually failing to absorb oxygen. Something else entirely was going on here.
Digging deeper, the team ran a CT scan, mostly to rule out a pulmonary embolism, a blood clot in the lungs. Thankfully, no clots. But the scan did reveal something else entirely, a massive, ascending aortic aneurysm. Basically, his aorta, which is the main blood vessel exiting the heart, was severely dilated. And this anatomical oddity? This was the first major clue to solving our puzzle. So, let's get into diagnosing the syndrome itself. The doctors realized they were actually dealing with platypnea orthodoxia syndrome, or POS for short. Now, I know that's a massive mouthful of a term, but break it down. Platypnea basically means shortness of breath when you're upright, and orthodoxia is the literal drop in blood oxygen in those exact same positions. Essentially, oxygen-poor venous blood was somehow completely bypassing the lungs and shunting directly into his arterial blood supply. But the million-dollar question was, where exactly was the leak?
The definitive proof finally came from what's called a bubble study echocardiogram. So doctors inject agitated saline, basically tiny microbubbles, into a vein. Normally, your lungs just filter these out. But looking at the ultrasound, you can quite literally see those bubbles crossing straight from the right atrium over to the left atrium in a single heartbeat. This confirmed a massive intracardiac leak. Unoxygenated blood was sneaking right across the upper chambers of his heart.
Now let's look at what created this perfect anatomical storm. That bubble study proved he had a patent foramen ovale, or a PFO. Now, before we're born, we all actually have this hole between our heart's upper chambers, simply because a fetus doesn't use its lungs to breathe. Typically, it seals right up shortly after birth, but for about 20 to 30% of the population, it stays partially open. And honestly, most of the time, it's completely harmless. But here's the thing. The PFO alone wasn't the actual culprit here. It was the combination of that PFO with a really dangerous set of age-related changes. Our patient had a pretty substantial 15-millimeter hole, yeah, but he also had a floppy intraatrial septum. Add in that severely dilated ascending aorta we saw in the CT scan earlier, well, the stage was perfectly set for a disaster.
Here is where the internal plumbing mechanics completely go awry. When the patient stood upright, gravity caused his enlarged, heavy aorta to actually shift downwards, physically pressing against the right atrium. Because his septum was floppy, This shifting literally pulled the PFO flap wide open, almost like a sail catching a sudden gust of wind. The unoxygenated blood was suddenly aimed directly through this gaping hole, completely bypassing the lungs.
This flowchart right from the medical report maps out exactly how posture triggers this crazy drop in oxygen. A simple change in position leads to a gravitational shift, which creates a transient pressure gradient. When you combine that with his pre-existing sleep apnea, which already increased his lung resistance, his heart essentially found the path of least resistance, and that path was straight through that open PFO the literal second he stood up.
And as you can see, patients with a PFO can actually be tipped into this dangerous syndrome by a whole variety of factors over time. It's not just aortic aneurysms. As outlined here, things like liver disease, abdominal surgeries, or even lung surgeries can alter the pressure gradients in the body just enough to trigger POS in someone who has quietly lived with a PFO their entire life without ever knowing it.
Okay, let's look at sealing the leak. Because this was a structural mechanical problem, the doctors needed a mechanical fix, ideally without resorting to open-heart surgery. So they opted for a transcatheter closure, essentially going in through a vein to plug the hole. Due to his distorted anatomy, a 35mm device actually failed at first, but doctors then successfully deployed a larger 37mm Gore occluder. It acts exactly like a cork in a leaking pipe, permanently clamping that floppy septum shut.
And the immediate payoff? It was absolutely incredible. Because they fixed the structural leak, they achieved an instant cure. The post-procedure bubble study showed virtually no bubbles crossing over. Within just 3 hours of sealing the PFO, this 90-something man was completely weaned off all supplemental oxygen. He was breathing comfortably whether he was sitting, standing, or lying down. A total game changer.
So what is the key medical takeaway here?
The absolutely crucial takeaway from this explainer is that POIS requires a very high index of clinical suspicion. If a patient is desaturating only when they're upright, pumping them full of more oxygen just won't fix it. You have to look for that internal shunt. As our bodies age, our anatomy shifts. Things like aortic dilation or even spinal changes can turn a lifelong, completely benign defect like a PFO into a sudden, life-threatening hazard.
Which leaves us with this final kind of wild thought. Roughly 20 to 30% of the general population is walking around right now with an undetected PFO. So, as our population ages and experiences these internal structural shifts, how many more unexplained medical mysteries, cleverly disguised as regular shortness of breath, are simply hiding right inside the human heart, just waiting for someone to connect the dots? It's a fascinating reminder of what a complex, mechanical wonder the human body really is.